DHA, prescribed BID, which I don't think is necessary, and they did GLA. So recall gamma-linolenic acid was also low in this patient, and gamma-linolenic acid is anti-inflammatory as long as it's given with EPA. And so she got robust amounts of both with a good antioxidant support blend. Arguably, we need antioxidants when we're prescribing omega-3s because omega-3s are polyunsaturated. There's a lot of double bonds. They're vulnerable to oxidative stress, but certainly in a patient where you see increased oxidative stress on laboratory evaluation or who has such a potent chronic inflammatory condition, you want to be thinking about extra antioxidants either in supplement form or, in a good antioxidant dense diet. This intervention alone was sufficient to turn around her asthma. I have not seen such a simple intervention generally work in my practice working with treating asthmatics. We do well in functional medicine treating asthmatics, but it usually takes a full functional approach to turn things around. Some cases, and there are some publications on this, we can make a big dent just by using a good essential fatty acid blend, and in this case, the addition of an antioxidant. We can think, so in immune cells, I would say it's going to be up to about 4 weeks to really turn around the ratio of 6 and 3. So we're starting to supplement with omega-3s. We're dropping dietary intake of omega-6s. We might start to see a change in about 4 weeks. It really depends on the life of the white blood cell. Some are short, some are in some T memory or B memory cells that are years long. By comparison, in red blood cell membrane, we're going to be seeing a change in a minimum of 120 days, which is the lifespan of a red blood cell. Generally speaking, we're looking at red blood cells. We're not measuring immune cells, but just to give you an idea of when you might expect to see shifts. There's an interesting collection, a small collection of case studies looking at severe traumatic brain injury. I'm posting one here using massive amounts of EPA and DHA. So in this particular study, using a full 20 grams of EPA and DHA. And it appearing to radically reduce inflammation, and basically, they've attributed it to saving this teenager's life, who wasn't expected to survive. Why? Well, we certainly think one of the reasons is, recall, DHA, main player, main polyunsaturated in the brain. DHA produces a host of these derivative compounds called resolvins, and there's a whole class of ones that are specific. They're called neuroprotectins, so specific for the central nervous system, and I'll show you more about that later. So sometimes very aggressive high dose amounts could be indicated, and I'm paying attention to more case reports in this arena. Unless major changes are enacted now, the timetable predicted is for the global collapse of all taxa currently fished by the mid-21st century to 100%. That's pretty dramatic. I hope we've started to turn the tides. We absolutely have to be mindful of where we're sourcing our omega-3s. Once upon a time, we always recommended wild caught, and we still prioritize wild caught, especially appropriately managed wild caught. There are also very safe, very high quality farm raised sources as well. And I'm recommending farm raised sources where care is used and there's full transparency in what's being fed in the environment and the care of the fish that I think is worth considering now. Epa and Dh sources in your toolkit, you'll find the various foods, the fish, the quantity of omega-3s present. Also in the toolkit, fish and toxins, safe seafood guidelines. So again, if you're going wild caught, what forms are safe to eat, what forms you need to eat in moderation, and what forms are absolutely needing to be avoided. Alpha-linolenic acid. So this is the first essential fatty acid in the omega-3 cascade. We cannot make alpha-linolenic acid, just as we cannot make linoleic acid in our bodies. We can, once we ingest these, use the desaturase and elongase enzymes to produce these derivative fatty acids. But in the first step in the omega-3 is ALA. My favorite ALA source is flax. You can get ALA in walnut, soy, chia, canola, hemp. I don't recommend canola or soy very often, but they do have some ALA in them. ALA can be converted to EPA, up to 10%. So it's a long process. It's going through a couple of enzymatic steps. We don't do it efficiently. And then even less will be converted down to DHA. More women, premenopausal women, are more effective at this, because, obviously the fetus is in high demand. Again, remember the developing neurological system requires DHA. So premenopausal women are more effective at this. But by and large, we're not doing this efficiently. So again, thinking about your vegetarian patients, you need to test and lean into algae if you want to get to higher doses. And you're going to have to use a number of different foods and probably, ALA oil sources. One of the neat things about alpha-linolenic acid is that it has high binding affinity for delta-6 desaturase, and it reduces linoleic acid conversion to arachidonic acid. So one good use of ALA is that you'll drop production of pro-inflammatory arachidonic acid. Genetic variation in human desaturases and elongases actually can significantly inhibit conversion. In fact, in South Asian populations who were traditionally vegetarian, they were very efficient at converting ALA down to EPA and DHA. They had a genetic variant, or they have a genetic variant that just allows for that to happen efficiently. Unfortunately, if you have that mutation and you adopt a Western diet and you're consuming mostly linoleic acid, you're making loads of arachidonic acid. So genetic variants can inhibit or turn up the volume on the desaturases. And the best way to find that out, I think, is just really through laboratory testing to see what's going on with your patient. Looking at the research on alpha-linolenic acid, it generally appears to exert an anti-inflammatory benefit. It's mild compared to EPA and DHA. It's probably due to the conversion of ALA down to EPA and DHA, and it may have something to do with its ability to inhibit production of arachidonic acid. So all of the three bullets in these two slides show some benefit, but this fourth bullet here showed no benefit, although these individuals were who did not have significant inflammatory factors. So the take home for me is ALA has mild anti-inflammatory benefit. As I've said a couple times now, I think flax seeds are the way to go because of the lignin presence. It's over 800-fold the amount in most foods. It's a superfood because of these lignins. They're antimitotic, anti-angiogenic, they're antioxidant, they're phytoestrogenic in a safe way. So consider whole flax seeds when you can. Sometimes you need to lean on flax oil, particularly in our vegetarian patients. Prostate cancer tumor proliferation rates were significantly lower, actually significant, the P 0.002 among men who were ingesting an ounce of flaxseed per day. Again, in your toolkit, you can see sources of essential fatty acids. What about concerns with using too much omega-3 fatty acids? So I think we've largely addressed it. We don't, by and large, need to be concerned with dwarfing arachidonic acid or dwarfing the omega-6s in quantity. If you go back and look at the reference ranges, omega-6s are far greater, and really we're just trying to bring omega-3s up. Even with aggressive supplementation, we're not going to be excessively inhibiting omega-6s by and large. We don't need to be concerned with increased risk of bleeding, according to really all of these large, well-run studies coming out. I think we can put that to rest. And here's another study looking at cardiac surgery patients. Again, same thing. They argued that it doesn't support the need for discontinuation of fish oil prior to surgery or other invasive procedures. Now, I've talked carefully about the potential for AFib, and this study outlines the U-curve potential. So people at the lowest and highest, specifically percentage of DHA in RBCs, had the greatest risk of postoperative AFib. I encourage you to drill down into that a little bit. This author, Metcalf, suggests achieving an omega-6 index of about 9.2 to 10.4%. Are we concerned about ALA and increased risk for prostate cancer? No. In fact, this study, this 2014 or 2013 study, got so much attention in my world, but with a bullet that there was a 50% decreased risk with the highest relative trans fat intake, I think this study needs to have a redo. I don't think the evidence on prostate cancer and alpha linolenic acid is strong. Fish oil and prostate cancer. So there's some human studies that have yielded conflicting results. However, looking at the literature carefully, it just doesn't support a relationship. Going back to gamma-linolenic acid, it's an omega-6. Gamma-linolenic is to dihomogamma-linolenic acid, and it produces a host of anti-inflammatory eicosanoids. I think these two fatty acids are compounds, well, hopefully a lipidologist at some point will really dive into the science. I think their time is yet to come. I think they're important players. There's some fair research on them, but clinically, a lot of us have good experience with them. So this is looking at Natural Standard database. You can see that they've rated GLA very low. Likely the problem with standalone GLA studies is the fact that it converts, quite readily to arachidonic acid unless EPA is given. So my argument would be a lot of the studies on GLA have not been run appropriately. Thinking about these enzymes and how we can influence them and thereby increase production of omega-3s while reducing arachidonic acid production. How can we influence desaturase and longase activity? So sterol regulatory element binding protein over here, SREBP1C. It's the transcription factor that upregulates production of the desaturases and the elongases, and actually fatty acid synthase itself. Insulin turns it up. Glucagon, so in the fasting state or in a low carb state, it inhibits it. EPA and DHA actually inhibits this transcription factor as well. So we can inhibit the production of these enzymes, and they're mostly going to be moving omega, linoleic down to arachidonic. We can inhibit through these favorable changes. In fact, this is thought to be the mechanism, the hypertriglyceridemic effect, the hypotriglyceridemic effect of using high-dose fish oil. Other factors that can influence enzyme activity, we've talked about substrate competition using EPA and ALA. Genetic variants can obviously influence how the enzymes are functioning. Age will slow down these enzyme activities. Sex hormones will influence. So higher in premenopausal women with more estrogen. Alcohol, glucocorticoids, adrenaline can all negatively influence these. Really, arguably, the easiest way to tell what's going on, is using lab testing as you're able to. We want to think about the cofactors involved. Magnesium, niacin, zinc, B6, vitamin C are all needed for efficient production of omega-3s. All right, back to one of my favorite topics, and this is the resolvins. These are the derivative compounds produced by all of the polyunsaturated, or both omega-3 and omega-6 polyunsaturates. It's believed that chronic inflammation is a failure of resolution. I think it's probably both ends, right? An increased in inflammation for various reasons, but then also we're not quenching it adequately either. These resolvins are essential for inflammation resolution, as the name implies. We make many different types of resolvins coming from arachidonic acid, DHA, EPA. There are aspirin-triggered resolvins. Interestingly enough, a low-dose aspirin, so a baby aspirin, can help promote some of these. And this might be the beneficial effects we see in some studies on baby aspirin. Recall, arachidonic acid produces lipoxins, which then stimulate the initiation of resolution, and then EPA and DHA come in and do more of the heavy lifting. DHA specifically has neuroprotectants, which are working in the central nervous system. They shut inflammation down. So they're liberated from the same white blood cells, and they say, they stop the party and clean things up. They, take up the apoptotic debris, cells exit via the lymphatics, diapedesis is reduced, and things are cleaned up. A baby aspirin is effective for the aspirin triggered. If you go too high, so if you use a full dose of aspirin, or if you use a nonsteroidal anti-inflammatory, you can inhibit the production of resolvins. And that's important. And that's a reason to be, careful with our use of NSAIDs. And it may be why we see chronic inflammation. There's a massive overuse of nonsteroidal anti-inflammatories inhibiting. So we want to inhibit the arachidonic acid-derived pro-inflammatory eicosanoids, but we need to allow some activity for the lipoxins to kick in. I think the botanicals, our lifestyle interventions using omega-3 fatty acids, the functional approach is arguably the better in the long run. So bottom line with resolvins, use the omega-3 prescription as outlined. There are some individuals who don't make resolvins as efficiently. In fact, people on the cardiometabolic continuum might not be. You can supplement. Resolvins are available, so you might consider those. I think quenching inflammation, resolving cardiometabolic imbalance will allow for resolvin production to increase. Resolvins don't cover all the omega-3 bases. Omega-3s are pleiotropic and work beyond just resolvins, although they're an important piece of the puzzle. Laboratory assessment of fatty acids. Fortunately, there are our mainstream labs, our standard reference labs are offering pretty good assessments of fatty acids, and we can get decent insurance coverage. I think we're in a good time for being able to make sure people's omega-3s and 6s are optimized. Arguably the best specimen for laboratory assessments are red blood cells or a blood spot. Plasma or serum really reflects immediate dietary intake. So blood spot or red blood cell are the best. The omega-3 index report, I think, is a great tool. This is looking at the red blood cell membrane, making sure that it's at least 8% omega-3, EPA, and DHA. This is an affordable test. It's a blood spot. And in my patients, I would consider looking at it around every 6 months. And once you get them well established or within range, and then maybe annually, you can do it as a checkup. Early on, the lifespan of a red blood cell is 120 days. So you should expect, if you start somebody on a therapeutic protocol, you should expect to see, a sufficient change in about that time. And here's the risk zones. We want to go up above 8%. Now, arguably, in our patients vulnerable to AFib, as I started our talk out, mentioning, we don't want them much higher than 8%, but we also don't want them lower than 4%. We don't all absorb fatty acids equally, and this is another reason why testing is helpful. There can be a lot of variability. Also, there's absorption issue. different fatty acid products have different levels of bioavailability. Again, I think ethyl ester is less bioavailable, but, the Reduce-It study used ethyl ester and the outcome speak for themselves. If you're going to use an ethyl ester form versus a triglyceride form, again, you just need to test to make sure you're achieving your therapeutic goals. Some more laboratory tests looking at various patients from my practice with inflammatory conditions, just showing, classically higher arachidonic acid and very low EPA. So here's a patient with ALS who stopped consuming fish once he had the ALS diagnosis because he was concerned about toxicity. And you can see his AA-EPA ratio was very high. So AA was in circulation 66 times higher than EPA. Another patient with rheumatoid arthritis, very high, 142 times the EPA was her arachidonic acid. And here's a patient in my practice with atopic dermatitis. So really different phenotypic presentations of inflammatory conditions, but underlying we see, very high AA relative to EPA. As I covered in the beginning of this presentation, we have a detailed omega-3 prescription for inflammatory diseases, and all of the following slides will cover our approach, including dosing and types of products to be used. Additional considerations, even though the research suggests that omega-3 fatty acids do not contribute to increased risk of bleeding, you can monitor PT-INR if you feel like you need to with your patients who are on blood thinners. Immunosuppressed individuals, so lowering AA might not be desired. Again, just lean on laboratories to make that assessment. Monitor fatty acids in patients and consider lipid peroxides as well for those you're concerned about increased oxidative stress. Check sources for sustainability, be mindful of toxicity, use clean sources, verify oxidation status of the supplements that you're using, use reputable companies you've vetted and you trust. Ensure adequate antioxidant intake, be that through diet or through supplements. Thank you.
Well, thank you, Dr. Fitzgerald, for a deeper dive into the essential fatty acid prescription. We're now going to have a little bit of discussion about essential fatty acids, go over some case studies, go over some questions that we often get around essential fatty acids. So we'll start that with a poll. So this should come up. You should click on that. We want to ask you a treatment question. In the treatment of inflammatory conditions, how many of you currently use, and you should select all of them that apply. Don't select all of them if they don't apply, but do you use dietary changes to increase omega-3s, supplemental plant sources of omega-3s, supplemental fish sources of omega-3s, supplemental omega-3 DHA non-fish sources, so algae, supplemental omega-6 GLA sources, so evening primrose, blackcurrant, borage, etc. So we're getting a number of responses, obviously. Many of you are using supplemental omega-3 fish sources. Almost all of you use dietary changes, which is great. That's foundational. And then you're all using, well, many of you, again, as we can see, over half are using supplemental plant sources of omega-3s, supplemental non-fish sources. I'm surprised of omega-3s, so DHA, that's quite a few of you. That's great, 40%. And not so many are using GLA, and we'll talk a little bit more about that. Kara, any comments on any of these responses? Surprise you, not surprise you?
They're not surprising, although there is a trend towards more non-fish EPA and DHA sources, which is really kind of interesting and kind of neat. I would love to see, as I mentioned, more research on GLA and DGLA, and I think those are two fatty acid whose times have yet to come, and I suspect over the years we'll see increased supplementation with those as we understand them a little bit better. The one other comment I wanted to make is, I think an important one, that we can change the 6:3 ratio by dropping insulin. So insulin drives the elongase and desaturase enzymes, and since there's omega-6 in quantity dwarfs omega-3, if we're on the cardiometabolic continuum, we're going to drive a poor ratio. So just dropping carbs, and paying attention to diet from that vantage point will favorably shift the ratio. So you don't even have to directly give omega-3s, and you can favorably shift it with those dietary changes.
Great point. So let's go on to a question that you talked about, fatty acid analysis. How often do you order a fatty acid analysis, and in what particular situations?
So once upon a time, it was a fairly expensive ask, for us. And I would be using a broad fatty acid analysis in patients who were a little bit of a head scratcher. Maybe I didn't think that, they had a neurological condition, or I didn't think that they were absorbing well, or some kind of a refractory condition might flag me, malabsorption, et cetera. Today, we're able to get a pretty good analysis covered by insurance in a lot of cases, and I'm using them more and more often. I think we can get omega-3 index or some version of that through standard reference labs, and I think it absolutely informs how we treat patients. And so these days, most of the people I'm working with have some laboratory data on fatty acids.
Affordable and cost effective. So
and useful.
Yep. Yeah. I'm glad you brought that up. It's becoming easier to order those. Let's go to another poll. This is along the lines of what just getting a little bit, diving a little bit deeper into if you currently prescribe GLA, do you always prescribe it with EPA DHA? And what Dr. Fitzgerald talked about is likely to trying to prescribe them together. We see that many of you are prescribing, when you do prescribe GLA, which from that previous poll is not that many of you, but when you do, you're prescribing it singly often, or 50%. Kara, any comments about this?
Yeah, probably, poorer study outcomes looking at GLA is because it was not prescribed with EPA. So I think it's clear from the research that if you use GLA as a standalone fatty acid, it will convert to arachidonic acid. So the very thing that you're trying to inhibit, inflammation, you're actually promoting if you use GLA as a standalone. So better outcome requires that you use it with EPA. And you don't have to use massive amounts of EPA to inhibit that conversion.
Yeah, I think that's another great point. So maybe 500 EPA DHA to 500 milligrams, I should say.
Yeah, that's it. That's that in the Chilton studies, that's all they used. And if we're using EPA in our patients, we're generally going more than 500. So it's nothing that we have to worry about. Yeah. But if you're going to use GLA, do use it with EPA.
Great. So let's get into a few other questions that we often get. So the first one, at what point after starting treatment with omega-3s would you strongly encourage patients to stop taking their NSAIDs, especially for those who are very attached to their NSAIDs? How do you respond to that question, Kara?
Two major things have to happen that I just want to underscore over and over. You need to do the dietary changes. So if somebody's got, is on the cardiometabolic continuum at all, you want to drop insulin, increase insulin sensitivity, because that will help change that 6:3 ratio. That'll increase omega-3s in the lipid membrane. And studies suggest that you really need to be sticking with a therapeutic dose for 3 months before you're really going to feel the change. So you're dropping inflammation, you're changing the diet and you're packing the lipid membrane with adequate omega-3s to really quench pain. So I would, I would be looking in the long game. I would be looking at around 3 months. That said, from a practice, my clinical experience is that patients will discontinue or taper themselves down on their NSAIDs, much sooner.
And so the second question here, krill oil. Do you use krill oil? How does that compare in terms of the other EFA sources?
I don't use krill. I mean, I was so excited when krill started to sort of come out, and there was some suggestive research that it might be more effective. I mean, it does have astaxanthin, which I think is an important molecule in its own right, but I think it's just an ecological issue, over farming krill. It takes a lot to achieve a therapeutic dose with krill. So there's many reasons right now that outweigh, using it.
And you mentioned briefly SPM, specialized pro-resolving mediators. Can you talk about your therapeutic use of those as supplements?
I think I'm pretty excited about the possibility of SPMs. I do use them therapeutically. One of the neat things is they appear in my own, I've done some informal trials here in my practice. They seem to work acutely if you dose them, a couple times per day. They've got a relatively short half-life. So pay attention to SPMs. They're important. I think exogenous use can be effective, but we want to ensure that people are able to make them endogenously as well. So that you need to have enough omega-3s. SPMs don't replace omega-3s. Another interesting study. There's so much research on SPMs. If you're curious about it, hop into the literature. It's an endless, interesting read. But there is some hypotheses coming out around COVID, and of course, the cytokine storm happening. That's important part of the pathogenesis and the higher rate of mortality, and SPMs may be important here, and an inadequate production of SPM may be what is driving this cytokine storm. Remember, lipoxin is required to initiate inflammation resolution, and then EPA DHA derived resolvins are needed to keep cleaning it up. Cardiometabolic conditions probably don't make these resolvins as effective, and of course those are the key comorbidities in COVID. So, not just our chronic inflammatory conditions, but acute inflammatory conditions such as COVID may lend themselves to thinking about omega-3s and SPMs.
Well stated. We'll go to one more poll here. And Dr. Fitzgerald talked quite a bit about delta-6 desaturase, delta-5 desaturase. So from her talk, what are likely inhibitors of D6D? And again, and this is a cloud, so use one word or a hyphenated word. Alcohol, insulin or hyperinsulinemia, obesity, EPA.
Yep, good.
Yeah, I think they were listening to you. That's excellent.
Well, there's a key one that's missing. I'm not seeing it here yet.
Well, wait a minute. What I see that simple sugars, sugar. What do you see that's
ALA, flax.
ALA.
The mighty flax or chia. My patients tend to like chia a little bit better. I think nutrient-wise, flax might win that race, although people would argue with me.
Well, you made a lot of good points about whole flax and the lignans and lignins, not just the ALA. So whole flax has a lot of benefits. Let's go to the last question here to get your insight on around Apoe. Do you routinely check Apoe status before giving high doses of EPA DHA?
Well, I do my laboratory workup before I initiate treatment. So most So patients these days tend to know their Apoe status before they come to our clinic, and we're a bit of a tertiary care functional medicine place. And I think that's, we just draw folks who've already done some extensive investigations. So they either know it or we'll do it in a baseline analysis before I initiate treatment. So by and large, yes, we do know Apoe status. Absolutely, we give fatty acids, and when we're trying to change that omega-3 omega-6 ratio, we want to see the omega index up at around 10% in this population. Monounsaturates, so poly and monos are better. In the saturated fat arena, we're looking at, the medium chain triglycerides, I think, as being very important in this population, because I think ketosis, some ketone production, which we can make more readily using a short chain or a medium chain fatty acid is important for these folks. So I do dose higher fats with these guys. I'm lowering, though, concurrently insulin resistance. So I want to correct that with the change to this fatty acid intervention. I think those two pieces are essential, especially in our ApoE4 patients. And I'll do an advanced lipid panel to see how they're responding to the fats. Some folks do better on whole foods. So just a high fat fish diet may be more effective in certain ApoE4 folks than using supplements, but it's fairly individualized. So yep, I use fats. Yep, I look at how they respond. I look at omega-3 index, et cetera.
And do you make a big distinction in a ketogenic diet of supplementing with monounsaturates and polyunsaturates as opposed to saturated fats in this ApoE4 genotype population?
Yep. I'll lean more towards mono and polys. I think some saturates are fine. I'm leaning more towards the medium chain triglycerides, and then the shorter medium chain triglycerides, like an 8-length MCT. However, when things are cleaned up, when inflammation is quenched, when there is no evidence of insulin resistance, maybe somebody's practicing a little bit of fasting or intermittent fasting, they can tolerate more fats. And the research actually kind of bears that out.
Dr. Messier will be talking after lunch about some differential research around monounsaturates versus saturates and looking at lipopolysaccharides and intestinal permeability. She'll actually after lunch, and I think on the third day as well, she's going to talk some about that. So we'll get more into that as well. So I want to thank you, Kara, for really some rapid fire answers to some very important questions. So at this point, we're going to take a break, and I want to bring your attention to something that we've put together internally. In your course materials, I want to encourage you to explore this interactive program that allows you to explore what Dr. Fitzgerald introduced and